is. So the malocclusion, all of you know that malocclusion, it is the deviation from the accepted normal occlusion. So the etiology is the essential order to prevent. So first, why you should know the etiology, that is very, very important for the diagnosis and the treatment planning. So to prevent, intercept and correct your malocclusions, you have to know, you have to be thorough with your etiology. So that is the main basis of understanding your etiology. So the malocclusions and the dental facial deformities result not only from the pathological process, but also there is disturbance of your normal growth and development. There is disturbances of normal growth and development. So the various systems of classification, it is clear, no? Audible, no?
Yes, sir, it is audible, sir, it is audible.
Audible, not clear,
Yes,
okay,
sir.
okay.
Yes, sir.
So the various systems of classification, as we all know, we have the White and Gardners, the Salzmans, the Moyers, the Grabbers, and the Profits. So many are there, but at the UG level, at the final year level, you are supposed to know the Moyers classification and the Grabbers classification. Moyers classification is a modification of your Dockrell's equation. The Dockrell's equation, you see it in the 2 marks area. Okay, the Dockrell's equation or the Moyers classification. The Dockrell's Moyers has modified this into the 7 categories. So the Moyers has given this in the year 1972. So Moyers has taken it from the Dockrell's article, which he has published in the 1952. So that is the basis for your Moyers etiology of classification. So basically it is into 7 categories. So this is your Dockrell's equation. The causes act at times on tissues producing the results. So this has arrived. This is also called the orthodontic equation. You can see here. So most of the things, whichever you see in your textbooks, everything is evidence-based. So wherever possible in your theory papers, you should be able to put down the correct terminology. That is very, very important. The terminologies are very, very important. Don't change the terminologies. So this is, you can see here, the evidence here below the slide, you can see from Dockrell's, from the classifying etiology of malocclusion, okay, in the year 1952. So Moyers has taken this as the guide and prepared the Dockrell's equation. So the Moyers classification, you have heredity, developmental defects, trauma, physical agents, habits, and the disease, and malnutrition. These are the 7 categories. So we will discuss all the 7 categories in detail. That is the main classification which you see in your papers, final year papers regularly. What you see is your Grabbers. So etiology, don't underestimate this topic. It has been there. I have put up the questionnaires, all the questions also, if you have seen. Here I have put up on the website long back. Okay, almost 3 weeks back I have put up. There you have a PDF of all the old papers, 10 years old papers. So go through the papers also. As the topics are covered, you should go through the old papers. Okay, so if you see the papers, it is an essay question. This etiology of malocclusion, you see classify etiology of malocclusion, discuss in detail about Graeber's classification. Or in Graeber's, you will be asked the Graeber's general factors. General factors are nothing but the same thing, the Moyers-Dockrell's equation. Okay, then you have the local factors. So the Salzman, if you see, he has again divided. See, basically this prenatal. Okay, prenatal or the intrauterine life, it is nothing but genetic, differentiative, and congenital. So the postnatal you can see here. The right side you can see the postnatal, you see the developmental, functional, and environmental factors. So the White and Gardner's, he has given a different classification, but this need not be remembered for you. Okay, so this you can just, yes, based on the dental base abnormalities, pre and post eruptions. He has divided it like this. Okay, then you have the profits also, but the most widely used is he has designed into another way, but the most important for you is the Moyers-Dockrell's equation, those 7 categories. Then you have the Graeber's general and local factors. The general is nothing but your extrinsic factors. So the local is your intrinsic factors. So the Graeber's general factors, you have these 8 categories. If you just go through your 3rd year textbook, I made you write this. Okay, so if you find the 3rd year book, just refresh it, then you can add up. If some of you, if you have missed that class, so you can take from your friends. So the Graeber's general factors, we have 8 categories. Okay, these are the 8 categories which I'll discuss now for you. So the hereditary, the first one. Okay, the pattern, this is the hereditary, all of you know, is the genetics based on your genetical. Hereditary is based on the genetical blueprint. Okay, blueprint is your DNA. Okay, based on the DNA which you inherit. Okay, so then you have the racial and familial characteristics. So the genetical, see this, so all of you should try and remember the main genes, okay, which are responsible for the craniofacial complex. The homeobox gene, this you will see in the short question. Okay, the 2 marks, somewhere you will find about the homeobox genes. Okay, these are the genes, and the genes of particular interest. You see, these are all the different genes. The MSX1 and MSX2, this also you will be asked in the exams. Okay, the Hawks group, the MSX1 and 2, the DLX, the OTS, the GSC. Okay, and the Sonic Hedgehog, SHH genes. So this list you should be able to remember. Okay. So after the hereditary factors, the genes, then the hereditary, continuing with your hereditary factors, the facial typing. Okay, so the facial typing, this is also hereditary based on the genes, the brachycephalic, the dolichocephalic, and the mesocephalic. When you come to the diagnosis, we will get into the details. So when you take case history, all this you will be recording. This entire thing you will be recording, the facial typing, the class 1, class 2, and class 3 types. Okay, class 1 is nothing but your protrusive convex profiles. Then the class 2, and you have the class 3. Okay, so the other factors that coming to your intraoral and the facial factors, you can see, which are affected by the heredity. The tooth size, the arch length, okay, the crowding, spacing, all these depend on the hereditary. Genetically, it will be inherited. So the family history, you will have to record the family history properly, and you see similar malocclusion. When you see the patient, if you should observe the parents also. If you see the parents with the similar malocclusion, you will have to record that. Okay, that will be useful for the diagnosis and treatment planning. So the hereditary also plays a role in the congenital deformities. Okay, this is also very important. The congenital deformities you see here, most of the congenital deformities, the facial asymmetry, size of position of the jaws, this will come under the local factors that we will discuss later if you see. So the congenital defects, you have the cleft lip and palate. Then you have the different syndromes. All the different syndromes will have to, all these are the short questions you might find in some papers. Okay, oral medicine, oral surgery, wherever. These syndromes you'll have to remember, and you'll have questions on cleft lip and palate regarding classification or etiology on the cleft lip and palate. So the cleft, that is a separate talk for you, the cleft lip and palate. The second part of your final year, we will get into these details. The cleft lip and palate, you can see here the unilateral and bilateral cleft lip. Then the syndromes, all the various syndromes. Although the percentage of syndromes is very less, but whenever you find a case, you will have to check all the clinical features, intraoral features. Then you have to correlate, then discuss. In case of doubt, you will have to discuss with the oral medicine and the radiologists. So this Crozon syndrome you see here, you can see there, post-surgical and pre-surgical, see the profile, post-surgical, see the profile. So most of the syndromes are treated with your distraction osteogenesis. Okay, these are the intraoral features. Then you have the next subheading is your environmental factors. Okay, the prenatal factors, the trauma, maternal diet, all the fetal posture, all these things. Okay, prenatal and postnatal. Postnatal will be the birth injuries during the delivery, or all that. Then the TMJ injuries, then the accidents and fractures. So some injuries happen during the fetal molding. Okay, then you have sometimes fractures might be there, and sometimes there is muscle dysfunction. Trauma to the mandible also. Okay, trauma to mandible, this is very, very frequent in the earlier years. Now things have changed because of the advancements. So the childhood fractures, muscle dysfunction. So what will happen when there is muscle dysfunction? So when there is muscle dysfunction, that part of the bone may not develop based on your functional matrix theory. So that is the importance of muscle dysfunction. So based on your muscle pull only, your skeleton will be formed, the bone will be forming. So the metabolic factors and diseases. Okay, this is also the different, the measles, mumps, chickenpox, all these febrile diseases. Then you have the different polio, all these things. Okay, then you have, of course, the endocrinal disorders. It is very, very high nowadays in the younger generation. The thyroid, parathyroid problems. Okay, hypothyroidism you will see very young now. In the teens itself, there is hypothyroidism. So you'll have to be very careful recording your case histories. So the case history is very, very important. You have to the medical health, everything. So when you have thyroid like that, so you'll have to be very careful. It will have an effect on the bone. So any young patient, if you see there is bone loss, the patient in teens or early adults, if you see bone loss, then you'll have to suspect some health problem. Okay, so that is the importance of all this. So the drugs are of drugs affecting the teratogens. This is very important. So the teratogens affecting the dentofacial developments. All these are your teratogens. All this is a big list. Aspirin, okay, dilantin, ethyl alcohol, all this thalidomide, and the radiations and the excess of vitamin D. So the diet is also very important. The poor diet may cause deficiency diseases. Okay, so this will again we'll have to see again here. You can, if it will interfere with your, so this diet also very, very important. Okay, that history during the recording your histories, that is why it is so important to eliminate the etiology. Then to go ahead with your diagnosis and treatment planning, and then the treatment. So this also will interfere with your craniofacial growth and development. So then you might find bone loss here also. You can see there. Okay. So the posture not so important, but still it may be a contributing factor. The posture of the patient might sometimes give you some clues. So the habits, all of you know the different habits, thumb sucking, tongue thrusting, the main important ones, the thumb sucking, you can see here. So the thumb sucking, you can see what it does to the maxilla. You can see here. Is maxillary protrusion. There are effects on the skeletal system. Then the dental system. You can see all the three tissues are affected. The skeletal, the dental, then the soft tissues. Okay, that is the importance here. It has an effect on all the three tissues. Come to the mandible, you see here. The mandible is pushed in, the maxilla is pushed out, affecting all the three tissue systems: skeletal, dental, and soft tissue. So that is why you should record properly the etiology. Thumb sucking, you can see there. Thumb sucking, how it is treated. There goes, somebody switched on the. So the tongue thrusting, the next one, the tongue thrusting, you can see here. What the tongue thrusting does, your dentition here by the skeleton, okay, skeletal. So you have the tongue thrusting, you can see here, the anterior open bite, okay, anterior, there will be spacing in the anteriors, okay, both the maxilla and the mandible, there will be spacing in the anteriors. So you can, the treatment, you can plan accordingly depending on your tongue thrust, okay. So the local factors, these are all the local factors you see here, okay. So the local factors, the category, okay. The slow factors, all this all of you have, you'll have to refresh your first year, second year, okay. The anomalies of number, the supernumerary teeth, the missing teeth, Okay, the agenesis, all the different anomalies. Okay, the tooth size and shape, the peg laterals, hypodontia, all these things. So each one has a different way of treating this. These local factors are also very, very important. Each one has a different method of treating in orthodontics. And in fact, these are complicated cases also. Problems with the local factors, these are little complicated. The treatment planning and the mechanics will be very, very complicated. The mechanics. You have to give more focus on the different mechanics, and it becomes not a single department treatment. Then these such type of cases will become interdisciplinary. We have to interact with the perio. If you see their improperly contoured restorations, you need to refer the patient to endodontics department. Orthodontics or oral surgeon or periodontics department. Very, very important. The local factors of treatment. So the anomalies of your tooth number, supernumerary teeth and congenitally missing teeth. So the tooth shape anomalies, all of you can refresh your first 2 years. You can see all those things, the tail and the peg laterals, and even the root is also very, very important for the orthodontist. The root to the root in the bone. So if there is a dilatation, that is why all had a fusion case, okay, which we interacted with the people department and we finished that case. Grafting procedures. This is done in the grafting procedures. You do the grafting procedures in cleft lip patients. Okay, the primary grafting and the secondary grafting. So hyperplasia you see here. So when we find such case, we had few cases of this hyperplasia also. So phenytoin. So we had to refer it to periodontia department, and every 3 to 6 months, once in 3 months or 3 to 6 months, we keep sending the patient, and again they will be doing the gingivoplasty, tooth size. So all these, most of the local factors, these are they become interdisciplinary cases. Okay. Ectopic eruption, lots of cases are there in the department. The ectopic eruption, you know what is ectopic eruption, all of you? Tooth erupts away from the original position. Okay. The most commonly affected tooth for ectopic eruption is your canines. Okay. Congenital absence of lateral incisors. Supernumerary teeth, this is also very, very frequent. Supernumerary teeth, slightly, the treatment is much simpler. For the supernumerary teeth, maximum you will have some midline diastemas. Okay, so the midline, very advanced orthodontic techniques we have now. So that's it. So the etiology of malocclusion, we'll have to be very, very thorough, and it is an important question also for you. Okay. Bargo, Bargo, unmute చేయమ్మా.
సార్ మీ దగ్గరే ఉంది సార్, మీరే ఒకసారి మేనేజ్ పార్టిసిపెంట్స్ ఓపెన్ చేసి అన్మ్యూట్ ఆల్ అని కొడితే.
ఇక్కడే ఉందా? ఓకే ఓకే ఓకే. సో the next class, hello
sir.
Mohit, so all of you so hope all of you are safe at home.
Yes, sir.
Yeah, don't go out, don't move around.
Okay, sir.
with your friends.
Yes.
Take care and be safe. So the next class I will inform the CR. Okay.